respected chairperson and delegates. First of all, I thank Dr. Ayappan and team for inviting me to this nice conference. So, my talk is on arthroscopic fixation of acute AC joint dislocation. So, as all of us know, AC joint injuries account for 12% of all injuries to the shoulder girdle in the overall population. And Rakud has classified very nicely depending on the severity of this injury from type 1 to type 6. And there is a consensus on the treatment of these injuries also for type 1, type 2, that is managed by conservative treatment. Type 4, 5, 6 managed operatively, but the dilemma is in type 3 management, where most of the surgeons, they tell that type 3 can be managed conservatively, but many literature also support operative treatment for type 3 injuries. So fixation options, traditionally we know the K-wire fixation, tension band wiring, Bosworth screw and hook plate, because they have their own disadvantages. So newer implants have come into picture, like tightrope, twin tail tightrope and fiber tape dogman button kind of thing. So coming to the case history, it's a 32-year male with a history of fall from own bike due to road traffic accident, sustained injury left shoulder, tenderness and deformity over the left AC joint, X-ray showed type 5 AC joint dislocation. So we planned for a fixation by surgical arthroscopic technique. So coming to the surgical technique, this is the specialized instrument jig which we should use while doing the fixation by arthroscopic method. And we prefer 2 dog bone button and 2 fiber tape for better fixation and less implant related complication and better strength. So I do all my cases in lateral decubitus position, and for AC joint fixation, 3 portals are very essential: posterior, anterior and anterolateral portals. Coming to the surgical technique proper, so first you should do the diagnostic scopy to rule out any other associated injuries, because fixing AC joint by arthroscopic method, the only indication and the most important indication to rule out the associated injuries and to treat the associated injuries. So once you rule out all this, then you go ahead with creation of anterior portal, which is a very important portal. And it's better to use a flexible this passport cannula for better handling of the instrument. So we put the passport cannula in the anterior portal, then start with the debridement of the rotator interval. And as we go on with the debridement of the rotator interval, we take out sometimes the middle glenohumeral ligament also. And very gently and nicely you should prepare the coracoid with the shaver and RF system. And then you create an anterolateral portal. It can be used as a viewing portal or a working portal. But the most important thing is to clear out the soft tissue underneath the coracoid. Subcoracoid decompression is very important, so that you can nicely see the under surface of the coracoid and the angle of the coracoid. So once you see this, then you can nicely put your implant at the intended point as you want to put underneath the coracoid. Then bring this AC joint jig and put it at the intended point, and then pass a guide wire from outside through a small incision over the clavicle, and it should come out inside the joint over a protection like curette. Then you remeet with a reamer, and typically you should feel all the 4 cortices, or you can take the help of a C-arm while doing this, and you should see under vision the reamer is coming out. Then you pass your nitinol wire loop through the reamer and retrieve it, and then once it is retrieved, then you gently take out the reamer by hand rotation, and then you load your fiber tape and dog bone construct over the leading suture, and then pull it on the clavicle from the clavicular side. And as you pull from the clavicular side, then hold this dog bone button with the help of a grasper, so as to deploy this dog bone button just underneath the coracoid process. Once you deploy it under the coracoid process, then outside you take another dog bone button and load it over the 2 fiber tape. And then with the help of a blunt instrument, you reduce the AC joint, take the help of C-arm if possible, and then you tighten your nut. And finally, you recheck your button through the scope from underneath the coracoid. And if you are having any horizontal instability, then the same fiber tape can be taken for the AC joint fixation as well. So this is the final picture, post-op X-ray and pre-op X-ray, and post-op rehab sling for initial 6 weeks, passive mobilization and pendulum exercises as soon as the pain relieved. Active abduction and flexion is started after 2 weeks up to 30 degree and gradually increased to 90 degree. Full active motion is allowed after 10 weeks and strengthening exercises after 3 months. Thank you very much.
Doc, what is the size of the drill in the clavicle? Size of the drill in the clavicle?
4 mm.
Sir, what is your threshold for chronicity? Would you do it in a chronic patient also, or would you accept only first
No,
few
only
weeks?
in acute scenarios, maybe up to 6 weeks, I go ahead with the arthroscopic fixation.
Yeah, because anything more than that, you need a biological graft to replace your tendons. Otherwise, the fixation is going to fail over time.
Yes, yes.
So continuing with your point, sir, I think there's a debate whether you need, this is the non-biological fixation, whether you need a biological fixation, in what patients you need a biological fixation. So do you have any criteria when you want to do a CC ligament reconstruction along with this, or only just do fixation like this?
So I think within the period of 3 weeks or 3 to 6 weeks when I am fixing it acutely, so I am just giving a support or augmentation to my healing ligament of CC ligament, and so that they will heal in the natural process. But anything beyond that period, invariably I use the grafts for the fixation.
One quick point. Anyone using this, and Ranajit, do you have patients coming back with complaints of knot irritation on the top of the shoulder after this implant?
Sir, if you put too many sutures, in 2 of my cases, initially I had to put 4, 5, 6 with this fiber tape, 2 fiber tapes and each 4, 5 knots.
Yeah.
Then they were complaining of this kind of. But of late I am putting just 1 or 2, because with first suture itself with the fiber tape, if it's a fiber wire, then you have to put too many sutures. With the first nut itself, it is a secure fixation, and over this 1 more knot is enough for the fixation. So the complaint is less of late.
Thank you.
How do you manage this anterior-posterior malalignment?
Sir, 2 methods I do. Suppose I see the horizontal instability at the starting, I first fix it with a K-wire and then I fix the AC joint. Or else after fixing the AC joint, I check the horizontal instability and then I take this fiber tape and loop it around the AC joint and do the fixation.
Because many a times when you do it on the anteroposterior view, it's beautiful. It is sitting right there, but anteroposteriorly it will be still subluxated. So that's something to note, that you get it right.
Thank you, sir.
Thank you, Ranjit sir.